There's Dr. Wright in the back, okay, who's Deputy Assistant Secretary and Director of Office of Disease Prevention Health Promotion, has been acting ASH, has been acting Secretary of the Department. It's kind of a joke when anybody resigns from government at a high level. We send him a congratulations. You know, we heard you were just appointed as the Deputy of Homeland Security or whatever. But he's had just about every position in government and done incredibly well. Yes, ma'am. We met earlier.
Hi, yes. Hi, Stacy Lindau, University of Chicago. Thank you for your talk. On the last questions you posed, the second of the two, I wonder to what degree we can think about the investment in addressing non-medical factors affecting health as an infrastructure investment. And if we think of it as an infrastructure investment, the business model or the ROI on that investment looks different. I mean, I suppose in that case, when we think about infrastructure, we're pitching to the taxpayers. But I wonder whether that thinking is in your mind or has been part of discussions.
Yes, it's absolutely in my mind and in the administration's mind. So there are many ways to do this. It doesn't have to go through the American health insurance providers. It could certainly go through other means. And part of my job, and I am preaching on a daily basis about having health considerations in all things. And literally, talking at, to the White House level about health is not just a medical care issue. We have to take care of the medical care issue. That's clearly the case. But it could be infrastructure. It could be safe communities. It's hard to exercise if you don't have a safe community. It's hard to eat well if you have food insecurity, and that's kind of an oxymoron to people. If people who have food insecurity have a higher rate of obesity. But we all know how that does. So absolutely, infrastructure issues that are, quote, not in the medical care system, but are supported by other branches of the government are there. And you've got a great example of a colleague who, we have to do what's right across the board, but we have to be opportunistic now. And we have Dr. Carson as the Secretary of HUD. He gets it really, really well about if we're going to take care of issues like education and employment, public health issues, HIV, we need housing security along with that. So we have to look to our advantages. We have a lot of them now. Yes, ma'am. Oh, all right. We'll go back and forth. Okay.
Good morning. Shreya Kangovi from the University of Pennsylvania. Thank you for your focus on this work. I think a lot of our conversations today, as you've highlighted, are going to turn back to the business case and to the ROI. And something that's always troubled me is that many estimates out there are based on pre-post studies that are really plagued by regression to the mean, and there could be this potential for a hype that doesn't stand up to later scrutiny. To what extent are decision makers talking about this and aware of this slightly kind of misleading direction?
Well, I don't know about decision makers, but I'm not aware. That's one reason I'm holding the workshop. This is not my professional avocation and why we need to bring people together to understand. When you tell me there's a methodological issue that I need to take care of, I will listen to that and understand it, but I don't know it a priori. So I hope that you'll be able to point these really key methodological issues out and also the next level of translating them into what does that mean for policymakers. I will also say that this is not in a vacuum. Again, the Surgeon General is doing a report on health and the economy, creating another set of business cases of why we should support investments into health and the social determinants. That's going to be a major 1 to 2 year long Surgeon General study. So this is all part of a big kind of wave to bring the momentum for many different areas coming forward. Thank you, and I look forward to reading about that. I love statistics, and at least I know what regression to the mean is, so I'll know what you're doing. Yes, ma'am.
Good morning. I'm Liz Marshall. I'm a health educator with the Society for Public Health Education and personally a birth activist. So this is a question to you as a pediatrician. What changes would you like to see or is your office working on in the care of pregnant women, particularly Medicaid-insured pregnant women, that would address some of these social determinants of health?
So we are taking, as a department, a very big, deep dive right now into maternal mortality and maternal health care. And I can't say we have a conclusion to that yet. Sure. Because we really have a scientific and public health group. It's 90,000 people in the department, but we're having 10 to 12 people around the table to really focus on that, because I think It's not only not only a critically important issue in itself, but it's also sort of one of those kind of sentinel events for the whole system. That if we don't, and to me, if we don't fix vaccination, we can't fix anything. If we don't fix maternal mortality, we're really not going to fix anything, because it's such a summation kind of event of so many things that go on. I will tell you one thing, we're trying to broaden that discussion a little bit, even though there's a lot of discussion about maternal mortality. We're really trying to talk about the maternal child dyad, because I think it's very difficult, particularly as a pediatrician, to separate those things. And I think we get it sort of in opioid use disorder, because so many things are coming together about treating the family, not removing the child, treating them together. But we kind of have to expand that conversation across all maternal infant issues. So again, there's lots of activity around that. As you know, it's a relatively small number distributed across with a variety of causes, and we're looking for common denominators across that that we could really focus on. So if you have the answer, let me know. We'll be happy to work on that. But it is a very, very important topic that's across departments now.
Wonderful. Thank you.
Dr. DeSalvo.
Brett, first of all, just thank you for your extraordinary leadership in general, particularly also on this topic, and thank you to your team for everything that they're doing. In addition, I just want to acknowledge how wonderful the department has been broadly in thinking of levers it can pull to address the social determinants, particularly on the medical side. And as you say, there are broader opportunities at hand. The thing I'd love to hear you talk a bit about gets back to the science, which is why we're here today, and where I think many of us are concerned that the hype may not be grounded in really methodologically sound evidence. And as much of a believer as I am, I'd like to know that as we move forward, that the promise is going to be fulfilled for the people we want to serve. So I just wondered if you could share a bit about how the department, including perhaps the NIH, is thinking about really making a push to build a strong evidence base and build investigators across the country who are resourced and capable of doing work to understand the social determinants.
Yeah, so I think your comments are right on target, and I'm just going to tell you, I don't know what the NIH's position is on this and whether it's a major initiative for them to really focus on this. Part of what I hoped from this is also to understand what some of the gaps are. And I started hinting at that about, in 2014, 2015, 2016, there was a ton of papers on biological mechanisms of social determinants of health. That has tailed off. And I presume it's tailed off because people are really concerned about the methods that were used may not be adequate to move it forward, or, we're hitting a certain limit. So I would be very interested in understanding from this group or experts where the real need is. I think that's part of this. Again, if I had the answers to this, I wouldn't be doing the workshop. But I think we want to understand where the gaps are. And if you have a couple gaps you're worried about now, but Francis, we have a very tight relationship. Several of us in the department have been NIH investigators all our lives. This is what we've done. We understand the system. And they've been very responsive. And I'll be quite honest, a lot of our efforts has been on opioids. And, we just announced something that will go into the social determinants of health last week, is $350 million on the healing community study. So 4 communities in Kentucky, Ohio, New York, and Boston, to really bring everything together over a 3-year period, including housing, social services, to drop overdose rates by 40%. So we are very cognizant of that, but in the context of sort of disease entities like opioids or like cancer, but not as much the theoretical basis for social determinants overall. So if we need to focus on that, that's sort of Trans Institute, happy to advocate for that. Yes, sir.
Good morning. Thank you for your talk. I have a question. I will. Jeff Levy from George Washington University and the Funders Forum on Accountable Health. And I'm curious about where the department is moving in terms of, if you look at the value-based purchasing initiative that was just announced for primary care, where now that's, in a sense, a financial incentive for people to think about social determinants. But in order for the clinical system to address social determinants, it needs to have a partner and a structure out there that can actually address the social determinants. Because I don't think we're asking the healthcare system to take on housing, food insecurity, all of these issues and become a super,
Right,
provider.
exactly.
So where's the department in providing for those clinicians who now want to sign up for this new approach the infrastructure in their communities to set that larger table so that there is a handoff when someone is identified as needing to address a social determinant? One example is the accountable health communities that CMMI is supporting, but the capacity of communities to build those multi-sector collaboratives is relatively small. And so I'm curious as to whether the department is thinking about how it might invest in creating that capacity across the country so that value-based purchasing initiative has the best chance of succeeding.
So it's a very fair question, and I wish Adam Bowler were here, because Adam is really spearheading that effort. As each one of those has a senior advisor associated with that. So I don't know what is in his mind about that. Clearly, though, I think the approach of the administration across the board is to try to find community-based solutions in order to build that and not have so much of a top-down effort. Even in the opioids program, what we wind up doing, for better or for worse, and there are criticisms both ways, is we wind up channeling a whole lot of money to the states and let the states distribute them as long as they're in an evidence-based practice. In the HIV program, and I'm speaking about things that I know about because that I run, which is a different answer than you want, but I can't directly answer that, is we're entirely focused on community-based solutions. So even before the 2020 budget, we're going to put about $30 million into community-based plans to talk about what needs to happen in that community. And it could be, how do you test and link people? It's really getting out into the community, working with, quote, the social determinants in order to, because rural Mississippi is going to be very different from Baltimore, and we have to understand those differences, and we're going to focus on providing funds to those communities to build up those infrastructure. So I'm just saying our approach and I'm going to say as an administration has been, and you might expect this, right, that we don't have all the solutions, but we're really interested. The way we've done it is we need to make sure you're evidence-based, period, because if you're not evidence-based, we're not going to pay for it. And we know that evidence goes from A to C, but as long as you're dealing with evidence that is pretty good, we're going to fund your solutions to it. And I would imagine that that's the way we're going to go about it.
And so I would use HIV as a perfect example.
Yes.
That, Ryan White is a perfect example of a program where we invested over many decades now in building the infrastructure and the capacity to bring the right people to the table to address not just immediate healthcare needs, but also social determinants. But it took an investment in an infrastructure in every community across the country. And there needs to be a parallel effort if we're really going to succeed more broadly in addressing social determinants.
And again, I wish Adam were here. I don't know what the plans are on that level, but if that is a major outcome of this study, that you can't deal with a value-based transformation and dealing with the social determinants of health without a coincident parallel program that does things like Ryan White. And giving an analogy is very important because we can't boil the ocean here, but if we have an analogy of something that has really worked, or like we're envisioning the ending HIV epidemic in the U.S., how that has worked and has been championed by the president once we pitched it to him, I think that would be very helpful.
Good morning. Thank you for your talk. My name is Uche Uchendo. I'm a physician in internal medicine. I'm a consultant with Health Management Associates, but formerly I was Chief Officer for Health Equity at the United States Department of Veterans Affairs. So that's my connection to social determinants.
Yes, ma'am.
And I want to go, I like the two other questions you posed about what to do, and I'm going on the first one, how, where, and when to demonstrate effectiveness of investments. I think one of the things we tried with quality improvement during my tenure in the U.S. Department of Veterans Affairs was to connect some social determinants directly with healthcare measures. So, for instance, A1C diabetes has issues with food insecurity, walkability in community, and those kinds of things, and then breaking down the data in such a way that allows you to see in each community or in each section, in our own case, in our regions, what were the areas, spotlights where you could intervene. And then I hear you about evidence, but the problem with that is not too much work has been done in this space. So allowing the room for quality improvement, but then putting side by side with that investigators who can monitor in progress and then allow quality improvement tenets to be used to adjust as you go along. And there's not enough time to get into an example, but I also want to mention the fact that I think it's important to hold multiple sectors accountable. Right now, it's around value-based healthcare, and that's great that primary care and other people will become more aware and get engaged. But until you provide a bridge, because there's only so much that the healthcare sector can do. There are some things the healthcare sector should be doing, which is finding out these things, but being able to create a bridge between the health system and the society and the communities that allows these things to happen, I think it's important.
So fantastic comments. I'll say maybe three things. Number one is I think the Department of Veterans Affairs, it's had a lot of blemishes in the healthcare system, but it has done exceptional work, particularly on the social determinants. And if you look at veteran homelessness, for example,
correct.
I am so proud of the VA and to be in a country that takes care of veteran homelessness the way that they've done. One thing I will say about the VA, even though this is not quite true because people go in and out of the system, they own their patient population for a long period of time. So they can reap their investments over a long period of time, which is an advantage that not other systems often have. Now, ultimately, everybody's going to be cared for by Medicare, so I think there's a strong way to make cases for government providing things because we inherit everything at the end. The third piece that I really want to work on, I think the VA as an exemplar, one that I would really like to use as a means, but also an ends in of itself, is the Indian Health Service. The Indian Health Service, if you want to talk about social determinants of health in some of the most neediest areas of the world, you talk about Indian country. I'm very interested in that, obviously, because that's where the health needs are. But also we have 1,800 of our 6,500 Commissioned Corps officers who work for the Indian Health Service. The acting director is Admiral Mike Wiyaki, who's in the Commissioned Corps. So we have a lot of opportunities to change that. It may be as a model system. And we're going to do that on a micro way with HIV, focusing on Indian country. But I think we need to do it more broadly. The fourth thing I'll say is we're trying to create those bridges. And when I talked about the Surgeon General's report, the economic impact of health, he's not really focusing on the healthcare system. He's focusing on the business community to really try to make the understanding that if we don't invest in health and change the trajectory, their businesses will not be successful. U.S. economic competitiveness will go down the tubes. We're also making that case on the economic side of the administration, because once that's established, then everybody's on the same playing field going for the same way. So we're trying to build those bridges by creating the cases to make as many constituents as possible, that this is not just owned by the medical care system or the healthcare system. It has to be owned by the country, and if not, we're going to face the consequences, and they're real. The military gets it. Let me tell you, the DOD gets it. You can buy as many machines as you want, but if you don't have trained individuals who are actually going to understand how this works and to defend the country, we are up a creek, and if our trajectory is going, nobody will qualify for the military in the future. So I think more and more segments are getting that, and when you tell us to build the bridges, you figure out a place and we'll build it. The Surgeon General and I are on the street. I don't know if you know the Surgeon General. He is an absolutely fantastic individual who has passion and connects with people. That's why I don't want him in D.C. at all. I want him. If I see him, I ask him, why is he here? Because I want him to be on the streets, working with communities and organizations to make this happen. Are we done? Thank you all very much. Really appreciate it. Thank you.